Good afternoon. My name is Veronica Combs, and I work with Air Louisville, which is a new program in Louisville, Kentucky. Surprisingly, you'd never know from the name. We're working on a new way to treat asthma. And in the Ohio River Valley, typically, when someone says, "Oh, I have asthma," the answer is, "Well, good luck, because we live in a valley and we have the Ohio River Valley crud." I don't know if you've ever heard of that reference, Christine, but we got tired of that answer. We wanted to use a new digital health solution and data to make life easier for people living with asthma, give doctors a better way to work with their patients, and also give the city some data about air quality in our city. Unfortunately, we have a problem with pollution, and that only makes asthma worse for people living with it. So Air Louisville is working on several fronts to fix that problem. My name is Veronica Combs, and I'm the Director of Community Engagement for Air Louisville. I have several people with me today that are working actively to make our program a success, and they'll be sharing their thoughts and ideas about what we can do to make life with asthma easier. I wanted to say thank you very much to Insider Louisville. They are hosting us today, and Christine Vaughn works for Insider Louisville, and she is also a participant in our Air Louisville program. Do you want to say hello?
Hi. Thanks for having me. We appreciate it. And no problem with hosting. It's great.
We also have with us today Meredith Barrett, who is out in San Francisco.
Great. Hi, everybody. I am the Vice President of Science and Research at Propeller Health and have a background in environmental science and population health research, and have had the great privilege of working with our partners in Louisville for the last several years. So excited to be here.
We had a pilot program several years ago with a small number of people, and that was so successful, and Propeller and the city learned so much, we expanded it to this program this year. So definitely a hallmark of our success. Dr. Jim Sublett is the founder of Family Allergy and Asthma, and he helped us out in the pilot project and is also working with us on this expansion.
Hello, everyone. I've been involved in treating asthma patients for well over 35 years. So with the new innovations we have, this could be real exciting to help deliver better care for our patients.
In addition to wanting to have a better solution to then this is our geography and we have to live with it, Louisville often appears on the worst places to live with asthma list, and the Allergy and Asthma Foundation of America compiles that list, and Mike Tringale is the brain power behind that report, and he is helping us identify the problems in our city and also figure out how to get, he says we can't get off the list, but we can get out of the top 10, so that's our goal. Thank you for joining us today, Mike.
Great, so glad to be here. I'm the Senior Vice President of External Affairs at the Asthma and Allergy Foundation of America, and I've been there for 13 years, and this report is 12 years old. So I grew up at AFA with the report, so I'm looking forward to talking more about it.
And you have 12 years of data on Louisville and the other cities around the country that show up on the list.
That's right.
Yes. So I spoke with Mike earlier this year, and there's a lot of thought and a lot of data and a lot of calculations that go into this list. So to understand the challenge that we're facing, I wanted to get your short view of the report and what goes into the calculations and why Louisville ends up, if not number 1, then certainly in position 8 or position 10.
Great. Well, thank you for inviting me to talk about this report. It's become a critical vehicle, really, for us, not just to educate the public and patients about asthma and to remind people that asthma it's a complex disease that has a lot of factors that can either help or hinder the patient, but it also has become a great opportunity like this to talk to people who can make a difference in their community, because a lot of the things we measure are factors that can be affected by human behavior or by patient behavior or through public policy. So we're going to talk a little bit about that. It's kind of important to understand what the list isn't first. The list is not just a list of where the most asthma in America is. You can get a prevalence listing to see which is the population or the city that's most burdened by the largest number of asthma patients. That's not what this list is. What this list is a look at really what are the quality of life factors, or the factors that affect quality of life in each of these communities. Because unlike a lot of other diseases, our immediate environment, I don't just mean the outdoors, I mean the room you're in, the place you're shopping, the place your kids go to school, these environments can make a difference. They can either be supportive of your good air quality, or they can be detrimental to air quality, depending on the kind of asthma you have and your triggers. it can be a very personal set of factors for each patient. So what the report attempted to do 12 years ago, when we were designing the methodology, we thought, well, my goodness, we're getting thousands of calls from patients every year. We have a call center, and they're asking, where should I move? Where should I move with my asthma? My asthma is terrible, and I got to get out of Poughkeepsie or wherever. Well, an allergist would be the first one to tell you, you really shouldn't move. It's not about moving, because the triggers for your asthma could be many, and no matter where you move, you could be encountering a known problem for your asthma or an unknown problem. So it's not about moving, it's about improving. It's about understanding and improving your knowledge about asthma, getting properly diagnosed so you know what your triggers are, and then looking at where in the environment you can make a difference, either in your personal life, in your behaviors, or again through public policy. So we set out to design a study that would look at, well, what are those factors that are universal, or at least across the country. We can look at all the major 100 cities in the U.S. when compared like data about factors that affect the quality of life for somebody with asthma. So what we came up with was the Asthma Capitals is really a list of the most challenging places to live with asthma. Now we remind people, just because you're number 1 or number 100 doesn't mean you're out of the clear. Everyone on our list has some trouble. No matter where you live, there can be an asthma a trigger lurking or some factor. So we wanted to capture those. And essentially what we look at for all the cities are 3 broad categories. We look at prevalence factors, which are things like the estimated prevalence of the disease in that community, the crude death rate for asthma, because unfortunately people in America still die from asthma. We can't forget that. But we also look at the second category, which is what are the risk factors in those environments? Things like air quality, pollen, smoking laws. What's the poverty rate in those communities? We know that study after study reminds us that poverty and access to insurance are directly correlated with asthma outcomes. And then the third thing we look at are the medical factors, meaning what are the emergency rooms looking like? Are they filled with asthma patients? Are people overusing their medications? Are they underusing their medications? And are there enough allergists in those cities to treat unfortunately, the growing population of people with asthma? So it's those broad categories we look at for all these cities. Just a real quick sort of, let's turn the telescope up on Louisville. So Louisville's been on the list of these 100 cities from day one. And it's not necessarily because other cities are better or worse. We only look at the 100 most populated cities in the U.S., but among those 100 cities, they represent 55% of the entire U.S. population. So it's still it's a broad brush look at where most Americans live. And in Louisville, this year, it was number 21 on our list out of 100. The year before, in 2014, it was number 16. So it's going down the list, and we will talk a little bit more about each of the factors for Louisville, but one of the interesting phenomena of closed lists like this, where we're just looking at the same cities every year, sometimes cities go up because the other cities are going down, and sometimes cities go down because other cities are getting worse in factors. And some of that is what's happened to Louisville. But you're still in the top 25, and Louisville has some factors that make it still a city with a lot of problems, some of which we can deal with and some of which we just need to be aware of.
So, Dr. Sublett, you have an even longer perspective on treating allergy. Has allergy in Louisville? What's your reaction to the report, and how has things changed over the years? Have they gotten better or worse, or just fluctuate, as Mike said?
Well, I agree with what he said. I think one of the important things about this effort by AFA is that it's really raised awareness among the lay, especially the media, about asthma, and also the lay public, and recognizing that throughout the country we have perhaps pockets of more problems than others. One of the stories I like to tell about Louisville is that several years ago, I was actually at a meeting in Phoenix, Arizona, And Mike mentioned that we shouldn't tell our patients just to move to try to get away from their to improve their asthma. And actually, it's interesting that tradition comes back from the days they would send tuberculin patients to dry climates. It has nothing to do with asthma. But on the front page of the Phoenix newspaper, this was back in the era when people still read newspapers. On the front page, they had a patient they were featuring who had multiple intensive care admissions in Phoenix. And as it turns out, she had been advised by her primary care physician to move from Louisville, Kentucky to Phoenix to improve her asthma, and actually had gotten progressively worse. Not probably because she moved to Phoenix, just because she probably was not getting the type of care that she needed to get her asthma under control. So, certainly Louisville has its problems, as you mentioned. There's a lot of factors involved in the worldwide increasing epidemic related to asthma. And I just recently gave a talk on the allergy epidemic and the increasing worldwide problems we have. And I'm privileged as president of the American College of Allergy to travel around the world over the last couple of years. I've been in places as diverse as Cuba, and this was at the European allergy meetings in Spain. And we see a similar problem worldwide. And there's really a number of factors. One, Mike mentioned, is smoking. That's increasing, unfortunately, worldwide. We've kind of got a lid on it here in the U.S., but it's pretty well capped around 20%. Kentucky has a distinction, and Louisville's not. It's certainly part of this, of being one of the areas where we still have a tremendous amount of smoking. Other lifestyle issues like obesity. We used to think that maybe people with asthma were obese because of lack of inactivity, but now we recognize that worldwide that obesity is a factor, that actually the inflammatory substances that are found in obese tissue actually can be a problem, and increasing inflammation we see in the airways with asthma, so obesity is a factor. Just dietary issues that also increase the incidence of other what we call non-communicable diseases. So we've kind of done a good job in the last 100 years, especially with our public health efforts of decreasing infection, and with vaccines and so forth, we've been actually able to eradicate some of the more severe, life-threatening infectious diseases. But concurrent to that, we've had issues like indoor air pollution on the uptick, more smoking, all these other factors, dietary changes that have actually increased these other diseases that are not infectious. So we really have a challenge ahead of us, not only in Louisville, Kentucky, or in the U.S., but worldwide, in trying to help people deal with what we can do about this. And there are many factors involved. As an allergist, we certainly point out that the triggers are often at least initiated by allergic exposures. And then once that initiation occurs, and you have other factors like viral illnesses and air pollution, and both indoors and outdoors, that can contribute to the problem.
So we definitely have established the problem here, living in Louisville and not wanting to move and wanting to make things better here. Back in 2013, Ted Smith, who is the Chief of Innovation for the City of Louisville, worked with David Van Sickle, who founded Propeller Health, to distribute these sensors that fit on top of an asthma inhaler and help a patient remember to take their medicine, and provide lots of other feedback and just help in getting asthma under control. So Meredith, would you like to tell us about the Propeller solution and how it's helping patients?
Sure, absolutely. So I actually have our sensors right here. So we have these sensors that are able to fit on top of inhaled medications for asthma, and it's able to track where and when people are using their medications. And so it helps in a number of different ways. First, it helps patients be more informed and more aware about what their asthma is, what's happening with their asthma. So it's able to basically eliminate those burdensome, long, handwritten paper diaries of asthma management of the past. And so it allows for really passive, easy data collection. So patients are more aware about what's going on with their asthma. The Propeller system involves not only the sensors, but also mobile applications and web dashboards, so that we're able to share that information back with patients as well as their providers, their doctors and care teams. And so all of that information, we run an analytical engine in the background where we're looking at different patterns of inhaler use. We're able to provide that information back to patients in the mobile app and in the web dashboard, allowing them to see how they're doing over time, how their trends have changed, whether they're adhering to their daily controller medications as they should, and also to gain insight about what their personal environmental triggers might be. Every time that the inhaler is used, the sensor is able to capture the date and the time and the number of puffs taken. And when it's paired with a smartphone, the sensor and the smartphone are able to communicate, and the smartphone grabs a GPS location as well. So we have a lot of information about where and when people are using their medications. We can automatically pull in some information like weather information, air quality information, to really start to learn about what are some of the environmental conditions that might trigger someone's rescue medication use. So it's really helpful for individual patients. We also provide all of this information. The patient is able to share this information with their doctor, with their care teams. And that helps sort of inform the patient and provider relationship. It allows for a better conversation about how the patient is doing, really provides an objective assessment of asthma control and how the patient is doing with their adherence. And so that allows for informing a clinical care, maybe making tweaks and medication adjustments to be able to improve self-management. And because the data are real time, a care team or a doctor may be able to intervene early in the case of a patient who maybe uses their rescue inhaler 10 to 20 times in a day because of high pollen levels or poor air quality. It allows a care team to be able to reach out early, get them on the phone, or perhaps even into the office before that patient ends up in the emergency department or the hospital. So it really allows that early intervention. I think one of the coolest things that we're able to do with the data that we can collect from the sensors, and this has really been one of the focus areas of Louisville, is that we're able to take all of the data that we're able to collect across hundreds or eventually even thousands of people across Louisville, and use that data to try to better understand what's going on with asthma across the community. So we can identify hotspots of asthma. We can look for where those peaks are by day, even by hour, and then we can start to identify, well, what are some of the environmental risk factors that might be influencing those patterns of asthma? Is it poor air quality? Is it pollen? Is it patterns in traffic? Or is it maybe even neighborhood characteristics that might be influencing asthma, like indoor housing quality, indoor air quality, exposure to mold, etc.? And so I think that's probably one of the really exciting things about Air Louisville and what we're doing in Louisville in general, and really how we hope to be able to get Louisville off those worst lists, is by being able to identify some of the environmental risk factors influencing asthma in Louisville. And by identifying them, we can also figure out how do we address them. What are the interventions that might be most impactful to really help improve quality of life, reduce those environmental risk factors in Louisville.
So Air Louisville is unique in those ways, and it is also a pretty broad collaboration. Meredith wrote the grant that we applied to the Robert Wood Johnson Foundation, and they funded the grant, and the Institute for Healthy Air, Water, and Soil is partnering with Propeller and with the city and with groups like AFA and Family Allergy and Asthma as providers to get the word out to a lot of different patients, a lot of different people in the community. We're also working with employers to help them manage healthcare costs. Asthma is not the #1 healthcare cost for employers, but it is near the top. So as I mentioned, we did a pilot program back in 2013, and the Robert Wood Johnson Foundation was sufficiently impressed to help us reach out to more people, and we're hoping to enroll between 1,100 and 1,500 people. And one of those people that was one of the first to join the program was Christine. And whenever you're talking about health, you have to actually include in the conversation someone who has the health condition you're talking about. So, Christina, I'd just like to hear about your own personal experience with asthma and any impressions you have from using the sensor. You joined the program in February, I think. Is that right?
So the first time I heard about the sensor was actually I heard Christy Brown speak at a conference that I helped recruit her to speak at. I had no idea she was going to talk about it, and I approached her after and asked her about it during the initial pilot, and so I kind of forgot about it. And then I heard Ted, Veronica, and Christy speak again in February, right after I started with Untitled Louisville, and I was like, okay, this time I'm sticking with it. I'm going to get this sensor. We need to get this under control. As I'm using my inhaler in the middle of the talk. So I have had asthma pretty much my entire life. I didn't get diagnosed with it until I was in high school. And really, Dr. Sublett was the one that told me I'd had it since early on with some of the symptoms I told him about after he became my doctor in my late 20s. And discovered that there probably should have been stuff I should have been doing, but then it's kind of like this cycle. It bothers me, and then it doesn't, and then it bothers me. And then pretty much for the last 5 years, it's been a pain. So I'm really excited to hear about this program, what it does. Speaking of the medication and people not taking them, and insurance, and you go back and forth with jobs and insurance and coverage. And to my discovery, that insurance hate covering breathing medications because most of them aren't generic because of the new discovery of a lot of them. So it's a lot of out-of-pocket costs. And even as somebody that has a decent job and support, it's still really hard to afford that. So it's like you pick and choose. Okay, I need the rescue inhaler way above the inhaler.
Did we lose Veronica?
I think we may have.
I think so. We're going to let them pick up while they come back on.
Did we lose Veronica?
I think we did.
Okay.
I'm not sure if we're still on the broadcast or what is hinged with her.
Just pinged them on chat.
So it looks like Veronica has lost connection. They're going to be logging back in.
Medication. I've probably used the inhaler once because I ran a 5K, and I decided to be on the safe side and use it before running the 5K. But then I could go in and I could put that information in that it was exercise induced, that I used it as a precaution, not as a need, so that they had that information to say, okay, this was, she's healthy, but it's a precaution to make sure she doesn't pass out. And I can put notes in. So I really like that aspect of it. And I can also record when it's not healthy, when, this is.
Well,
We're back.
Technical difficulties. Sorry for that glitch in our internet connection.
So it's nice to be able to, like I said, to see the data, to be able to share it with my doctors, and for them to be able to look at the data and know where I was. And, we have both talked about, Mike and Dr. Sublett have both mentioned the moving thing, and I distinctly remember asking Dr. Sublett, should I just pick up and move? And he said, maybe to Antarctica? But no. And that's what I tell people all the time. I'm like, hey, my doctor told me not to move. And the idea is, there's dust in Arizona. And I'm allergic to everything. I mean, I look like I was beaten with a whip after an allergy test. And yes, it's quite. I have to have a family member come and hold. So, but.
And you're a pretty active person.
I am. I'm a
cyclist.
I'm a cyclist, and I pretend to be a runner. That's really not the truth. I'm more of a. And for some stupid reason, I signed up to learn how to do aerial and acrobatic sports yesterday. So we'll see how that goes. But yeah, the cycling thing, and it's really interesting to compete with other people and not be able to explain why you can't get a full breath or why you have to put a race because you're seeing stars because you can't get a full breath in. So hopefully my goal down the road is to not have that happen, to probably just be on maintenance medication. I am on prednisone daily for pretty much the rest of my life until we can get this under control. So my goal is to not be on that, to look at the different medications that are sustainable more so than that, or to complete them all together with the study, with the research, and hopefully improving the year. Even if that's 20 years down the road, it's still a goal to look towards.
Dr. Sublett, did you want to share a comment on any of that?
Well, I think her history is very typical of what we hear from patients and the challenges we have in healthcare, especially with the very high deductibles that some people face now with the retail benefits plans where you may have a $5,000 deductible before your insurance kicks in. And many of the allergy and asthma medicines are quite expensive if you have to pay for them out of pocket, and most people don't realize that. And we just had a quarterly doctor meeting with our 18 allergists in family allergy and asthma, along with our nurse practitioners. This past weekend, that was one of our topics, was try to, a couple things we try to do. The better control you get, the less meds you need, and then also get away as much as we can away from what we call polypharmacy, where people are required to take many medications. But even the reliever type inhalers are not inexpensive. So by identifying the usage or the appropriate use or overuse of these inhalers and moving patients to either step up or if you have individuals who have what we term difficult to control asthma, there are new medications that are coming down the pike, what we call biologicals. They can be, even though they're very expensive, they can be cost effective in that you're now moving a patient away from having to pay $300 for an inhaler each month to maybe a more costly medication that actually has a potential to dramatically change their asthma. Allergy immunotherapy is a very important piece of this, and it is now been shown in many studies, and CMS now recognizes that allergy immunotherapy is cost effective. Again, it's not accidental that both the Allergy and Asthma Foundation and our family allergy and asthma have allergy in the name right next to asthma, and that, as I mentioned earlier, a majority of these triggers are allergic. So if we can recognize and treat those more effectively. I think the propeller device is important, and I have several patients now who are from the original study we did that are continuing to use the device, and as was mentioned, we can proactively manage these patients. You can imagine if in our practice we have thousands and thousands of patients with asthma, and to try to monitor these patients on a daily basis with anything is very difficult. We for many years have used self-monitoring with peak flow measurements and other methods. The one advantage we have is we get an email, and then we can proactively, as we expand the program, our plan would be to proactively contact patients when we see that their asthma is maybe not out of control, but slipping toward being out of control. And we can have our triage nurses contact the patient, try to get them into the office appropriately when they really need to be seen. Because a lot of times people, they have trouble getting in. We still have a problem with nearly 20% of individuals with asthma do not have primary care physicians or a specialist. Only 20% have specialists involved. But around 20% use either urgent care, emergency departments, or the good and the bad of retail clinics. They have easy access, but they also don't have good long-term follow-up care, which all asthmatic patients need. So if you have 1 out of 5 patients using those types of healthcare facilities, they're not getting continuity care that they need to really get their asthma under good control. So there's a lot of pieces of the puzzle on the table, and we start putting these together, we should have better outcomes, which is the goal of all of us, I think, that are dealing with this really costly and life-impacting disorder.
So, Mike, I know that access to insurance is part of the calculation for the report, and Kentucky was one of the few southern states to expand Medicaid. So, in theory, more people have access to insurance. But are there any trends that you've noticed as far as cost of medication or access to actual medication?
Well, great point about the Medicaid expansion. That data, that effect may not be seen until next year's asthma capitals report, because we base the report based on the most currently available data, so it's mostly previous year, 2014 data. But you're absolutely right. We look at insurance, one of the critical factors under the risk factors is access to care, and the uninsured population, which is, of course, tracked. You don't have access to physicians or to medications that's timely and affordable, your asthma is going to be more difficult to control. Now, I want to go back and say, there's no conversation about asthma is complete without all of us reminding patients who are watching that you cannot manage asthma alone. Dr. Sublett is absolutely right, and Christine's story is a perfect example of what we hear all the time. You've got to work with an allergist and somebody who really understands asthma, mild, moderate, and severe. People who die from asthma aren't just severe asthmatics. You know, the intermittent nature of asthma, as Christine was describing, some seasons it's worse than others, sometimes it's worse than others, reminds us we see people, unfortunately, who are dying from asthma who have mild asthma, but they have a bad episode because of they're not well managed, they're not taking their medications, the environmental factors are conspiring to create a terrible environment. So it's just a reminder that you have to work with your healthcare provider and an allergist to really get the most optimal care. And the literature is full of that kind of evidence. But beyond that, a lot of patients don't realize that the clinical guidelines for asthma that come from the NIAID, actually, one of the core pillars of asthma care is controlling your environment. I think it's even listed before medications, actually, in the guidelines, that it's important that people need to recognize and understand, be educated about why their environment matters, why pollen counts matter, why pollution matters, why smoking bans matter. And these are come right out of the guidelines. Why dust mite covers on your bed matter. Why taking carpet out of the home. I mean, it's hundreds of things that we can do to improve the environment we live and work in and go to school in every single day. So when it comes to things we can do, in Louisville, for example, air quality. Good news about air quality, actually, in America is air quality is getting better. That a lot of people don't, even in the all the cross conversation on public policy related to air quality, American air quality is getting better. It's still not great, but it's getting better. It started at a bad place. Louisville comes in, I think if you look at the Louisville number, it comes in average compared to the other cities on the list, but again, the average was a C- on a scale A to F. So, right. Long way to go. Same thing for some other, like smoking laws. What we look for in the asthma capitals rankings is not just any smoking law. It has to be a 100% ban. So in other words, a ban for that particular location with no exceptions. And you'd be surprised how many people pass a smoking ban, but there are all kinds of exceptions for employees or for they might have a smoke-free restaurant, but they've got a smoking section one table over. So that's not a 100% ban. That's not serving the patient or the family who's trying to manage asthma. So that's another area where we can make a difference. We can get out there and talk to our policymakers about passing laws. Again, Louisville's done some good things. There are some smoking bans, 100% smoking bans in Louisville. Right now across the country, there were 4 different kinds that emerged. Smoking bans in the workplace, smoking bans in restaurants, and in bars. And then a 4th one, which has emerged, is smoking bans in cars with minors. So you see states like even Arkansas has passed that statewide. California, I think Maine is another one. So there's some innovative public policies out there that are really helping and supportive of the asthma patient. And these are things that we can do at our local town councils and in our state capitals all across the country that we want to see. One, let me point to an example of where we've had 100% success, just to prove that we can move the needle here, which is we look at, when we started this report back in 2002 or 2003, I can't do my basic math here, one of the big policy issues we were pushing, and I know Dr. Sublett was pushing for it too, was laws that allowed children to bring their asthma inhalers into school with them. And not just to have it locked up in the nurse's office, but to have it on their person. Believe it or not, 12 years ago, that was not a universal law across the country. Some students couldn't bring their inhalers into school. Well, since that time, and about 6 years ago, we had a universal 100%, all states now have a law on the books allowing access to inhalers and carriage of inhalers by children in their schools. So the challenge now is implementation and how that law is being worked. But it's an example where we've pushed on public policy and it worked. Now we need to do the same thing for air quality. Now we need to do the same thing for smoking bans.
Right, right. One thing is I'm out in the community talking to people about asthma and the propeller sensor and Air Louisville. Parents are the ones that always get it. When you say, you'll know when your child is using their inhaler, their eyes just light up and they say, I want that app right now and I want to sign my kid up for the program. And I think something that people don't have asthma don't understand is the importance of those daily meds. And you think, well, if you have a prescription from the doctor, you'll just use it. But if you're not sick, I mean, that sounds like your experience. If you're not feeling symptoms, you don't take the medicine because you're not feeling symptoms. Right. So medication adherence, that's the fancy term that people use, is really a problem with asthma. And I know that's been one of the benefits Propeller has found in looking at how people use this and how it changes their habits and what, how you get people to adherence. Meredith, do you want to talk about that a little bit?
Sure, absolutely. And as it's been mentioned, adherence to daily controller medications is a really difficult problem in asthma care. On average, seen across the literature, we see only about people take about 22% of the medications that they're actually prescribed. So it's a big issue. And yet, as also has been mentioned, adherence is one of the most impactful ways to get daily control of one's asthma, to be able to avoid exacerbations and avoid those emergency department visits, and also help reduce costs too. And so at Propeller, our approach has really been, well, how can we make adhering to those daily controller medications as easy as possible? And cost was one issue that's been mentioned as a barrier to adherence. Another one is just remembering to take your medication. So people live really busy lives, have a lot going on. Maybe it's a parent caring for a child. Maybe it's a two-household family. So it's really difficult to know and remember when to take those medications. And so one of the things that we've done at Propeller is to really set up a system so that we can remind people to take their medications, making it easier. So we can communicate with participants and patients through text messages, through push notifications on their phone, through emails, to remind them at those times of day when it's time to take their medications. Also, some of our most recent sensors also have lights and sounds, and so it'll actually beep and light up when it's time to take your medication. So that will definitely remind you when it's beeping in the bathroom. And so what we try to do is really not only remind, but also keep track of how a patient's doing with their medication adherence, so that it makes it really easy. They don't have to take tedious notes about which medications they took and when, and also we're trying to make it more transparent for the doctor to also know how well that patient is doing too in their adherence. It helps identify technique problems or other types of issues with medications. And we've seen it really work. So we've run a number of different clinical studies, and what we've seen is that when we have the sensors on the inhalers and are reminding and providing that feedback, we can more than double the average adherence that people have to their daily controller medications, which really helps impact asthma control.
And hopefully in the long run would save money in hospitalizations or constantly refilling your controller medication. I think one thing that I've learned so much about asthma, and attacks don't just happen, they sort of build up over time. So that's the other benefit of the system of seeing, what's different this week and what's changing, and let's intervene now instead of a week from now when you're in the emergency room.
Right. And we really, because we can collect the signal of both the daily controller medication and the rescue inhaler use, it actually makes that relationship even more clear for both patients and their providers too. So on weeks when somebody's doing really well with their adherence, they'll likely be using their rescue inhaler less. So then that makes that relationship of, oh, the better I do with my adherence, probably the better control I'm going to have. It makes that relationship very clear. One of the great stories that actually came out of the Louisville pilot was a story of a mom and her daughter, and the daughter got so much better in terms of using her daily controller medications that she improved in her control, and she was able to go off of her controller medication. So that's something that we want to see too, is people improving so much that they're able to really kind of take control of their asthma and not have to take as many medications as well.
Right, absolutely. So I think one of the reasons that I wanted to join this program is because it really does reach from the individual to doctors to employers trying to control healthcare costs all the way up to the city that is trying to clean up the air and figure out where asthma is worse in the county, in Jefferson County. And I think as I look toward, this is our enrollment year, so 2015, we're signing people up, we're distributing the sensor, we're talking to people, to patients using the sensor, to doctors and supporters helping us do this. And then next year we'll be tracking the data for a full year. At the end of the study, we're going to look at all the things Meredith mentioned. You know, what did the weather do this day that we had so many asthma attacks? Why are there so many more asthma attacks in this neighborhood than this neighborhood? And so patients will benefit from the data all along, but our partners in the city will benefit most probably at the end when we can create this map of asthma attacks in Jefferson County and see where the burden of asthma is biggest. So as I look ahead and work to recruit people this year and work with our partners and work with Propeller to make this program a success, I think I'm really looking forward to the point where I can look at data and make it mean something. People talk so much about big data, but as long as it's just figures in a spreadsheet or in a database somewhere, it doesn't really do anything. So to be able to work with the city and say, there's no trees in this neighborhood, the air quality is bad, and asthma attacks are terrible too. Let's spend money right there to fix things, and let's help those people living in that neighborhood as opposed to just more general, well, let's plant some trees and hope that they help with the air pollution burden. So that's what I'm looking forward to as we work through Air Louisville. Christine, what do you hope to get out of this program?
Just a better understanding of how I can control the asthma, and you know, there's no cure for it right now, so I'm hoping that maybe some of these studies, and I know that you guys have started to partner with the American Lung Association, and maybe sharing that data, and they focus a lot on cancers and lungs, but I think that they need to try and shift their focus a little bit. Not that cancer's not important, but you know, all of it's important. So I'm hoping that the partnerships that develop a better understanding of what asthma is and how it can be controlled and why it happens. It's also one of those things that people don't see, so until it happens, so obviously you're not sick. So I don't take a flight of stairs when I look perfectly healthy because I know when I get to the top I'm going to have an asthma attack. So, you know, hopefully with the work you guys are doing and spreading the word, people have a better understanding of it. Maybe there is a cure one day so that if I have children, they won't be affected by it. But if they are, there's studies that hopefully will help them. But that's really my long-term goal is to not be affected by it, to remember what it was like not to have to carry my inhaler with me everywhere that I go, and freak out if I don't have it, which just means an asthma attack anyway. So, you know, just the idea that one day that could happen with research and studying, getting rid of the term of, oh, I just live in the Ohio Valley, I'm stuck with it the rest of my life. That's really one of my long-term goals, is to be like, nope, I live here, I'm happy here, and I'm healthy here.
Right. Mike, what would success look like from your perspective for our Air Louisville program?
Well, I'll say it to you first. When you plant those trees in Louisville, make sure they're non-pollinating trees. You know, we consider when we talk about air pollution, we consider pollen to be air pollution for our constituents. You know, I think Christine just gave a great sort of summary for what we all hope for, which is so we hope for a cure at some point for asthma. But until there's a cure, it really is incumbent upon the patient. The patient is the one who lives with their lungs. A patient is the one who lives with the asthma burden. You know, health plans are on the outside, we're on the outside, even doctors are on the outside. It's the patient. So the patient needs to be the first one to become educated. Parents need to recognize the symptoms of asthma, not take for granted that it's just a recurring flu or a cold, or that when Jimmy can't play soccer or has trouble running halfway around the track, that they go to their pediatrician, get a referral to an allergist, and talk about asthma. Asthma is a very manageable disease. I've heard so much about how emergency room care is it's a harbinger of places where asthma is really not well controlled. Well, there really should be no asthma emergencies. I mean, if everybody were being treated by the right specialist and had the right, and were adherent to their medication therapies, we can really eliminate that burden. So until there's a cure, getting patients better educated, which is a responsibility we all have, and making sure that they're well managed is an achievable goal.
Dr. Sublette, what about you? What would you like to see?
I agree with what Mike just said. I think Christine's a perfect example. They're one of the founders of our specialty, Bela Schick, who started the first allergy clinic at Mount Sinai, New York City. He was a famous Austrian pediatrician, and his mantra was first the patient, second the patient, third the patient, fourth the patient, fifth the patient, and then compliance. And I think he nailed it. I think, you know, what we've always, Dr. Pollard and I, when we started our practice many years ago, and the doctors who've joined us, our mantra for us is, you know, having patient focus and trying to do everything we can around what benefits the patient. I think all the partnerships we're seeing here do a number of things. One, as I mentioned earlier, it raises the awareness of asthma. Too many times asthma has been trivialized. People trivialize allergy. Asthma is still the #1 reason children are hospitalized. As I mentioned, it's a tremendous burden. One of the interesting sidebars of the exchange, as you mentioned, is there's been an increase in emergency room visits and across the board, and part of that is access to specialty care. We need to realize that in order to have better care for these type of chronic illnesses I mentioned, we need more funding for that sort of thing at the governmental level, which is something I know Mike and myself and our organizations work on, is try to recognize if we have more access to specialty care. We still have around only 20% of asthmatics who really need to see specialists are doing that currently. But I think these types of programs here in Louisville will it raises the awareness. We have people in the community who are influencers in our community. Mayor Fisher has been a wonderful advocate for this program, and other individuals who are certainly community leaders. So I think my goal would be to, for every patient that has asthma, to have better care for them, better access to care, the proper type of care. And as Mike mentioned, we really need to take the emergency room visits, urgent care visits, certainly hospitalizations to zero, and certainly for the 4,000 patients or so who die from asthma each year, take that to zero. And that is possible. It may seem improbable, but we know from data we've collected that if you have specialty care, you can take the ED visits down to just minimal. And of course, being able to monitor better and help people understand when they are getting in trouble, that can be a real important tool. And that's one thing that Propeller brings to us, I think, is a real-time way of looking at it, not coming in 2 weeks later with their diary that they've written. We actually, as I mentioned earlier, be able to be proactive in their care.
So Meredith is the one who will be crunching all this data and looking at all the factors and working on an equation that I can only barely begin to understand. So Meredith will be the success of this program.
Great. Well, before the equation, I think it's important to reiterate the point that's been made several times, that really at the center of this whole program and all of our efforts is absolutely the patient. And really want to thank Christine for being here too. Our first and foremost goal is to help people live day-to-day better lives, being able to control their asthma. So living days where they don't have to use their rescue inhaler use, where they have asthma-free days and have improved control and don't have to go to the emergency department. That's what we're really looking to do. So overall better quality of life for patients. And what's so powerful about this program, I think, is that it's those patients that are at the core of this whole program. So it's Air Louisville is the largest citizen science data generation for an asthma study that's really ever been conducted. So it's those residents and patients who are really at the core, providing their data to really help us better understand what's going on with asthma in the Louisville community. So I think that's very, very powerful. And it's going to allow us to identify those hotspots of asthma, both temporally as well as where are those geographic locations where we see a lot of asthma rescue inhaler use. So identifying those hotspots, identifying the environmental risk factors that are influencing those hotspots. So is it the pollen, and if so, what type of pollen on that day, or is it air pollution, or is it emissions from traffic, or is it different neighborhood characteristics that may be influencing those asthma patterns? And I think we also have the opportunity to think about, well, what do we do about it? And so having policy impact is another huge goal for Air Louisville. So taking those insights about environmental risk factors and being able to think about different intervention scenarios. Should we plant trees in this neighborhood, or should we think about reducing car emissions in this area by improving public transportation, or should we think of a regional air pollution reduction program? Or maybe it's a combination of all of those interventions that will have the biggest bang for our buck in terms of improving overall quality of life for asthmatics and for everybody in Louisville. So really working with local partners, the local public health and wellness department, air quality, as well as the city of Louisville to really figure that out. And Veronica, as you mentioned, I think we're trying to take a pretty unique approach here, both really a program that's from the ground up with local residents and patients being a part of it, but also thinking about other partners to bring to the table. So the employers and health systems and health plans who really have a vested interest in keeping people healthier in the Louisville community. So thinking about how to make this sustainable and how to make it really collaborative to bring lots of different players to the table to think about really making long-term changes to help improve Louisville. So I'm really excited about how collective and collaborative this partnership has been, and I think we have a lot of potential to really make a difference and get Louisville off of that worst list. So thanks so much.
So yes, as you mentioned, Air Louisville is an enormous collaborative from patients like Christine up to national partners like the Asthma and Allergy Foundation. Thank you all very much for participating today. We are enrolling for the rest of the year, so you can go to airlouisville.com to find out more, or if this is a program that your employer might be interested in, you can reach us there as well. So please do join us. We're doing really innovative work that is making a huge difference. So thank you all for your time today, and we'll see you soon.
Great.
Wow.
Thank you.